We're going to switch gears and talk about intertrochanteric hip fractures. Disclosures are on the Academy website. So intertrochanteric hip fractures, they're very common. They account for approximately half of all hip fractures. They result in significant impacts on patients, and there's lack of conclusive evidence supporting any one treatment type. I think some things that are really critically important to consider when you're looking at an intertrochanteric fracture are the characteristics of the injury, what's an acceptable reduction, and what's an acceptable implant position. I'm going to try and go through those three things. So what to worry about preoperatively in terms of injury characteristics? I think you want to think about, is the fracture pattern unstable? Is there a reverse obliquity component? Is there subtrochanteric extension? What's the status of the lateral wall? Is it thin? How much displacement there is? And ones I worry about is where it's 100% displaced. And then what is the femoral bow of the femur if you're going to do a long nail as treatment for that fracture? And I think these characteristics really do influence implant choice and approach. So this is a fracture. You can see unstable fracture pattern, very thin lateral wall. It was treated with a sliding hip screw, and it went on to shorten significantly at a week. So this is not a great fracture to be treating with a sliding hip screw, particularly in a higher functioning patient. There's been a lot of evidence around lateral wall thickness. I think if you're at all concerned, you should try and avoid a sliding hip screw. I think displacement is a very significant factor to consider. So if the fracture is displaced more than 100%, then pretty much universally you're going to have to open the fracture to get a reduction. If you try and just pull on it, you won't reduce it, and that'll be a major problem. So this is one where I think you open it, reduce it, and then you get a good reduction. If you try and pull on it, you don't get any kind of reduction, and this is the negative outcome. So these are the kinds of fractures that you want to reduce, open. Femoral bow, I think, is also really, really critical. So you're looking at the top end of the femur, forgetting that there is an exaggerated bow in elderly patients, and that can result in a distal problem, a fracture or a nail perforation. So you want to make sure that the nail radius of curvature is appropriate for that femur. So if you look at outcomes, screw cutout is still a problem, both with plates and nails. And I think what really is key is reduction. And certainly, if you look at intertrochanteric fractures in North America, mostly they're being treated with nails. So I'm going to focus more on nails and reduction in the next few slides. If you look at risk factors associated with cutout, some of it is injury based, but a lot of it is factors that can be controlled by the surgeon. So particularly reduction of the fracture and where you're putting the implant. It's been shown that if you get a better reduction, your outcomes will be better. So what's an acceptable reduction? Well, I think absolutely key is to get your anteromedial calcar reduced. If that's not reduced, you're going to typically have a problem. You want to avoid translation. If you're going to have some malreduction, you in particular want to avoid negative medial cortical support, and we'll talk about what that means. You want to avoid anterior malreduction on the lateral, and I'll show you what's meant by that. You want to restore the neck shaft angle. That's absolutely critical. And varus, in particular varus of more than 10 degrees, is really negatively associated with poor outcomes, and you want to avoid distraction or medial gapping. So this is a nice paper that was published almost 10 years ago talking about calcar reduction. So if you're going to have it malreduced, you're better off having it malreduced positively as opposed to negatively. So negatively, there's no medial cortical support, and that's been shown to have an increased impact in terms of negative outcomes. So this is a case with intertrochanteric fracture. You can see displaced. It was treated with a sliding hip screw. Decent reduction. You could argue not perfectly reduced. You could see that the screw's not deep enough in the head, but you're looking at it and saying that's not too bad. But there are some, issues in addition to the depth of the screw. You've got a negative cortical reduction on the medial side, and you've got an anterior cortical malreduction on the lateral. So this patient goes on to cut out of the femoral head. Again, just emphasizing the critical importance of reduction in terms of getting a good outcome. It's a paper recently published in Core, so you can see In A, you've got an anterior malreduction. B, you've got a perfect reduction on the lateral. And C, there's a posterior malreduction. The anterior malreduction was associated with a 4.2 times greater odds of cutout. So you're trying to avoid an anterior malreduction, obviously trying for perfection, but if you're going to be off, you're better off to be a little bit more posterior. I think varus is also really critical. Here's a patient with a nailed fracture. If you're not sure, image the opposite limb. This patient had quite a bit more valgus on the opposite side. The implant position actually not bad, but this patient went on to fail, was re-reduced in a more valgus position and went on to heal. Distraction is also a problem, so if you got inframedial gapping, that can be associated with failure. So the bottom line is you need to do what it takes to get a good reduction. So if necessary, open it, and particularly in patients where there's 100% displacement, I will open it and use whatever adjunctive techniques you require to get that reduction. Implant position is also key. It's been shown tip to apex distance for sliding hip screws is important. That same principle holds for nails. The only subtle difference with nails is that there's actually some evidence to suggest that on the AP, if your screw position is a little more inferior, that's actually protective as opposed to a sliding hip screw where you're trying more so for center implant position. So cutout then, I think really isn't about the implant, it's about proper surgical technique. Cutout, if you're going to get it, usually relates to the quality of the reduction and implant application. I think in general for any nailing of a proximal femur fracture, you want to make sure that you're well reduced before reaming. You want to make sure you have a good entry point. You want to make sure you avoid further comminution and lateral drift. You want to be cognizant of the lag screw angle. Make sure you're thinking about the radius of curvature of the nail and the femur. Check for rotational deformity and make sure you atraumatically insert the nail. So again, this is one where I'm going to do an open reduction, put a clamp on it, make sure my entry point is good, that I'm well reduced, and then put the nail in. So what about the implant? There's been a lot of controversy in terms of nails and plates. There's no question in North America, more nails are done than plates. We recently published a study in JAMA Open, randomized controlled trial looking at IM nailing versus a sliding hip screw and trochanteric fractures in ambulatory patients. We had 850 patients internationally across 25 sites. And we essentially found no difference in ambulatory patients between a sliding hip screw and an IM nail. So there's no difference in functional outcome, no difference in mobility, no difference in adverse events. So for the average patient that has an intertrochanteric hip fracture, really the device is less important. What we're not certain of is what about the high-functioning, high-demand patient? So where maybe that displacement that occurs with the sliding hip screw is going to have a negative impact. So I would say evidence for the device in 2024, biomechanical results aren't supported by clinical results at long-term follow-up. There are no pivotal prospective RCTs that have shown superior outcomes with any implant or fixation methods, and data in the high-functioning patient really is lacking. I think what doesn't matter so much with a nail is nail diameter. So pretty much there's been a couple of studies now showing that a 10 millimeter nail works just fine with an intertrochanteric fracture. It's not necessary to fill the canal when you're putting the nail down. And nail design, I think, is really controversial. Some studies showing an integrated lag screw results in better outcomes, others showing that it's actually the same or detrimental. Short versus long nail, again, a lot of controversy. We actually looked in did a sub-study looking at the nailing patients in our INSIGHT trial, actually found more adverse events in the long IM nailing group. So I would say the most intertrochanteric fractures are going to be treated with a nail. You can do it safely with a short nail. So in conclusion, I think outcome with these injuries is most related to proper surgical technique, the quality of reduction and implant application, There are no pivotal RCTs that have shown a superior fixation with any specific device or method, and primary treatment is with well-done internal fixation in the vast majority of cases. Thanks very much.